everyone. I'm Dr. Nina. I'm the Director of TOVA Community Health in Delaware. And our mission here is to provide comprehensive, holistic, compassionate care to individuals living with complex chronic conditions like sickle cell disease. Today, for our TOVA Talk series, we are honoring World Sickle Cell Day, which has been held yearly since the United Nations presented a resolution in 2008. World Sickle Cell Day is actually on the same day as Juneteenth, National Independence Day. The United Nations and other countries will be celebrating World Sickle Cell Day this year, again on June 19th, to raise awareness and support those who suffer with sickle cell disease in order to share their experiences and what is going on in care and treatment to help them achieve their full potential. I am so lucky today to have our guest speaker, Dr. Ivy, talk with our community today. Dr. Ivy is the Vice Chief Medical Officer of the Sickle Cell Disease Association, and he is also a warrior, sickle cell warrior as well. So he has a unique perspective because he lives with sickle cell, but he is also a medical doctor as well. I'd like to just share Dr. Ivy's bio before we get started because I am always inspired by his great work, but also because he's so down to earth and so easy to talk to and very approachable. When you go to conferences, he's always willing to share his information. He's always willing to help and support those who are advocating for the sickle cell community. Dr. Ivy is the health education educator with the Association of Black Cardiologists. He also currently serves as the Vice Chief Medical Officer of the Sickle Cell Disease Association of America. Prior to joining the Association of Black Cardiologists and SCDAA, Dr. Ivy worked with the Maternal and Child Health Bureau and the Health Resources and Services Administration, HRSA, as the program director of the Hemoglobinopathies Program, which included the Sickle Cell Disease Treatment Demonstration Program, the Sickle Cell Disease Newborn Screening Program, and the Thalassemia Program. Dr. Ivy worked at the NHLBI, which is the National Heart, Lung, and Blood Institute, and he was a part of the team that developed the sickle cell disease treatment recommendations in 2014. Amazingly, Dr. Ivy completed his medical training at East Carolina University School of Medicine, and after starting a residency in pediatrics, Dr. Ivy realized his interest in public health and attended the University of North Carolina at Chapel Hill School of Public Health, where he received his master's in public health with honors. So without further ado, I want to welcome Dr. Ivy to TOVA Talk series today. So all of this saying, one of the areas which we were talking about that you wanted to share was about hydroxyurea. And, you know, hydroxyurea has been around since the mid-90s, and the New England Journal of Medicine, published this great research looking at adults with sickle cell and really showed that it can reduce hospitalizations and sickle cell pain crisis by half. And it is a good drug that helps a lot of people. Where are we today with hydroxyurea?
Yes, so thank you so much, Dr. Nina, for having me today. I'm honored to be invited as a guest to this TOVA Talk series about sickle cell disease. And as you brought up, I want to give a special, emphasis to, hey, sickle cell disease, World Sickle Cell Disease Day is on coming up, and we want to make sure that we're honoring not just the advancements that have been made in sickle cell disease, but also those individuals that have passed away from sickle cell disease that have been a part of really advancing that research. So giving a lot of honor to them. I'm so happy you asked first about hydroxyurea. Just real quickly to give a quick overview about sickle cell disease. It's a disease of the red blood cells in which a molecule inside the red blood cells called hemoglobin has a defect in individuals with sickle cell disease. That defect is due to a change in the DNA at one of the nucleotides, one of the components of DNA. And that single change in the DNA causes sickling of the red blood cells in low oxygen environment. But before we're born, our body makes what's called fetal hemoglobin. Fetal hemoglobin is made by individuals when they're in the womb. And shortly after birth, we start producing adult hemoglobin. And adult hemoglobin is where you have that defect that causes the problem in sickle cell disease. There are, continue to be individuals that are born with a situation where they have sickle cell disease, but they also have what's called persistent hemoglobin F. So yeah, their body switches over to the adult hemoglobin that has the sickle gene production that has the defect, but they also continue to make a high level of hemoglobin F after birth. So usually after birth, about 6 months, our hemoglobin F level drops down to 1 to 2%. In these individuals with persistent F, their hemoglobin F levels can stay as high as 10, 20, 30%. And what was observed was that, well, hey, individuals that have sickle cell disease, but they have this persistent hemoglobin F level, they had less disease than other individuals with sickle cell disease that didn't have that persistent hemoglobin F. So then it was hypothesized that, well, what if we were able to help individuals produce more hemoglobin F? What if we were able to decrease the percent of hemoglobin S, where the problem with sickle cell disease is, and increase or elevate that hemoglobin F level? And hydroxyurea, which was a drug that's been around since the 1800s. So it's not a new drug. It wasn't
I
just
didn't know
developed,
that.
in the 1990s, but it was used for other purposes since that 1800s. And it was used mainly to treat individuals that had blood cancer. So, if there were individuals that had a certain type of blood cancer, the hydroxyurea was a therapy to reduce the amount of red blood cells from that cancer. But what they noticed also in treating those individuals is that they decreased the production of like that adult hemoglobin and increased the production of fetal hemoglobin. And so, from that, the researchers said, well, what do we use this for sickle cell disease? We know that individuals that have high hemoglobin F levels have less disease. I'm going to say less because it doesn't cure an individual of sickle cell disease, but it decreases the amount of events they have, amount of pain crises, and amount of other bad events. And so the study was done, as you mentioned, and it was reported in the 1990s that hydroxyurea can be very effective at improving the outcomes in sickle cell disease. They looked at certain indicators or endpoints, and they found that, hey, giving hydroxyurea decreased the number of pain crises, decreased the number of certain events that would happen, like acute chest syndrome, and then also just made individuals have less complications with sickle cell disease. I personally started hydroxyurea in 1996. Shortly
Were you
after
on the
that.
Were you on the randomized clinical trial? Were you an original participant?
So that's an interesting question. I think I was put on the study, but I was put on the study as they were about kind of closing it out.
Oh, okay.
So they had already published the paper, as you mentioned. The study was still open because there's certain rules and regulations around doing the randomized controlled trial. So I was on it, but I wasn't one of the earlier individuals on it.
I was just going to give you your props,
Yes, and hey, I would love to take the props, but I have to, as I mentioned earlier, give those props to those individuals that came before me, that were willing to really take that risk, because participation in the clinical trial can be scary. And we can look back at certain events that have happened, like the Tuskegee experiment, what happened with Henrietta Lacks, and say, well, we don't want to participate in clinical trials because they're trying to poison us, or they're trying to kill us, or they're trying to do certain things to us. But we have to recognize that the way we advance and improve our learning and improve the number of treatments that we have is by participating in clinical trials. So I would definitely encourage individuals to participate if they feel comfortable. Now, not everybody's going to necessarily feel comfortable with participating in a clinical trial. And I would love to say, hey, I take props for participating early on, but I was one of the latecomers. I still was involved in the clinical trial, but I'm not one of the earlier participants. But as I mentioned, so I was in undergrad at North Carolina State University, and I had a very severe crisis with acute chest syndrome. Now, I was just as apprehensive or just as worried about, hey, starting a new drug as anyone else would be. I had questions. Well, what if this does this, or what if I develop cancer? And for me, what changed my thinking about it was something that my doctor had said. So I had just had an episode of acute chest syndrome. I was in the ICU, I think, for like 18 days.
Oh,
I had to be intubated the whole time. I had exchange transfusions done. And, sickle cell is a very severe disease. And so I was talking to the doctor and I was like, well, yeah, but what if it causes cancer? And he says, the doctor at the time, Dr. Eugene Oringer at UNC Chapel Hill, said to me, well, Donnell, I can't give you a clear answer on if it's going to cause cancer. Hey, it could. He said, but, you could take hydroxyurea, and 15, 20, 25 years from now, you could develop cancer from taking the hydroxyurea. But he said, but you have a very severe disease, and you just had a significant case of acute chest syndrome. So you could have another one of these in the next 6 months, and you can die from sickle cell disease. So I think what we have to keep in mind is that sickle cell disease itself is a very severe disease. And that if we don't pay attention to it, and if we don't treat it properly, it can kill us just as quickly as a cancer that can occur from the treatment 15, 20, 25 years from now. So we have to look at, how do we think about addressing our disease? Sure, we want to think about what happens to us in the future, but we have to make sure that we're also treating our disease in the present.
Yes, that is so true. And you have to balance the risk versus the benefits, like you said. Exactly. I also wanted to just share, I don't know if you can see the screen. You have an impressive bio, like we said, but I want to talk to you about it. You are a sickle cell warrior. What was it like growing up with sickle cell disease?
Yes, so that's an interesting question. Growing up with sickle cell disease, now, I was born in the 1970s, 1971 to be exact. It was an interesting time for sickle cell disease in that the U.S. had just passed certain sickle cell disease legislation. Richard Nixon had just passed the Sickle Cell Disease Treatment Act of 1971. And so it was an interesting time, but they did not know a lot about sickle cell disease when I was younger. I can remember going to the emergency room, and then all they could really do for me is give me oxygen, IV fluids, and then pain medication. But there was studies going on at the time that, even though I didn't benefit from them directly back then, they were starting to improve our understanding of sickle cell disease. Most important of those studies, there were two that were extremely important back in the 1970s, early 1980s. And there was one about penicillin prophylaxis. So when I was younger, and even now, I mean, children that have sickle cell disease, they're at an increased risk of death from infection. So an individual with sickle cell disease could get an infection, and it can be overwhelming for their immune system because of the disease burden also, and it caused a lot of death. So there were a lot of children that would die with sickle cell disease from infection. The penicillin prophylaxis study showed that giving penicillin prophylaxis to babies below a certain age improved life expectancy, improved outcomes, because it prevented those children from dying from the infection. Now, that was done, and what that did was open the door then for newborn screening. And so we learned strategies to identify babies that were at risk, that had sickle cell disease. And so then having the newborn screening and having the, now we know that penicillin prophylaxis improves outcomes, gave us the reason to start doing newborn screenings at the state level. And there were several states in the early 80s that adopted newborn screening to promote penicillin prophylaxis. Now,
Were
I
you
said
started on penicillin
I
early?
remember taking it when I was younger. I don't know if I took it because of the guidelines or because of the studies that had been done, but I remember being on penicillin quite frequently when I was
Mm-hmm.
younger. I remember getting a lot of infections and having pneumonia a couple of times and so forth. And I was fortunate that I did have, when I was much younger, access to those doctors. My stepfather was in the Air Force, so we had access to the healthcare system through my stepfather's employment. So I remember taking penicillin when I was younger, but I don't know if I was ever put on that penicillin prophylaxis protocol that we encourage all children to do today. The other study that I would just mention that came later, and I know I don't think I've ever done benefited from this study, but was also the transcranial Doppler ultrasound for stroke risk. So that was another study that was done that helped to identify individuals that would be at increased risk of having a stroke from sickle cell disease. And it was demonstrated, though, that if you identify individuals, so they'll do a transcranial Doppler ultrasound, they will, if you have elevated levels, they could identify that, hey, you're at risk of developing a stroke due to sickle cell disease, and then it can start you on exchange transfusion, chronic exchange transfusion, which could lower the risk of stroke. So I think those two events that happened, and this is prior to hydroxyurea, you're talking about my youth, were very important in improving and addressing sickle cell disease care. Now, my personal circumstances that my stepfather and my mother, they separated when I was about age 10. And I went to live with my grandmother, who had a different view on life and took a different approach. It's not an approach that I would advise to anyone, but it was pretty much that, even in crises, she would force me to do chores and do, that did give me that recognition of, hey, even if I'm not feeling well, I have responsibilities and I have to do certain things. It's not good to teach individuals that through that mechanism. We want to make sure that any individual with sickle cell disease is given the proper treatment, taken to get the proper care. But we do have to make sure that we're teaching our young people with sickle cell disease that, hey, when you're not sick, you have to try to be a part of society. You have to try to get out and learn as much as you can in school and participate in activities and try to be a productive person. We know that sickle cell disease is a burden, but it's one that we have to figure out how to live with, because the alternative is, of course, worse.
So I think your grandmother taught you resilient skills.
Yes,
like you've got to bounce back from
yes.
these sickle cell flare-ups. You still got to go to school. I still want you to be on the honor roll, and you're going to do some chores around the house. Yes. I'm not feeling sorry for you.
Exactly.
Is that correct?
Yes, it is. But to your point, though, so sickle cell care has improved immensely, and we've been fortunate to learn quite a bit about sickle cell disease. So hydroxyurea, it came out, like you had mentioned, in the 1990s. So prior to hydroxyurea, from what I understand, we still only had the IV fluids, give you some oxygen, pain medication. And for a while, hydroxyurea was the only therapy really that was out there to treat sickle cell disease in a disease-modifying way. Now, it was the only widely used therapy. I did some research just for this talk, and learned that actually the first bone marrow transplant for the treatment of sickle cell disease was done in 1984. So it's been a while since they've done the bone marrow transplant. And to just talk about that a little bit, as it was mentioned earlier, so sickle cell disease comes from the red blood cells. They have a defect in them, and our red blood cells are produced in our bone marrow. Our bone marrow makes all of the red blood cells for us. If I were to kill all of my bone marrow cells off and then take your bone marrow, then I start producing red blood cells that are like your red blood cells. And so, the concept that, hey, we can take an individual that has sickle cell disease. We know that their red blood cells are coming from the bone marrow. If we were to find a donor that did not have sickle cell disease and give a bone marrow transplant to that individual, then that would cure them of like sickle cell disease in the sense that they're now making red blood cells that are normal. And so they started doing those studies, as I said, in the mid 1980s. I remember hearing a lot about it in the 1990s. At the time, it was shown that adults were having more problems with the bone marrow transplant. And that could be due to, living a full life with sickle cell disease. And you get that end organ damage that can start very early. A child with sickle cell disease, yes, they might appear that, well, hey, aside from the pain they might have occasionally, that they're okay, but they could be having problems occur from repeated complications in sickle cell disease related to, as I mentioned earlier, the brain and possible strokes. We know that there's a such thing now as silent infarcts, where a person could have a silent stroke. They're not showing the outward signs of having a stroke, but they've had damage to their brain cells. We know that sickle cell can also affect your liver or lungs. So I mentioned earlier acute chest syndrome, and having that acute chest syndrome episode, even though it was that one time in 1995, there's scar tissue in my lungs related to the acute chest syndrome. But if we can catch individuals early enough before they have the really significant complications and do bone marrow transplant, then they can have good outcomes. And so that had been started we started doing the bone marrow transplants in the, like I said, the mid 1980s. And we started out with, you had to have a matching sibling donor. So if you didn't have a brother or sister,
the full sibling,
a sibling, yeah,
right,
that didn't have sickle cell disease, but they matched with you, then it wasn't available to you. Fortunately, as time went on, we got to where you can use unrelated donors for sickle cell disease, but the gold standard would still be that matching sibling donor. And then with any donor, you would have to look at the HLA typing and make sure that they match in a certain level, a certain percentage of those HLA subtypes.
So we know that there are individuals in the community that have been cured from sickle cell disease with bone marrow transplant. But now, when we're talking about, our topic today is transformative sickle cell care. In 2024, the FDA approved 2 curative treatments for sickle cell gene therapy. Yes. This is so exciting, but it's very also exciting. Scary as well. Can you talk to our community about gene therapy?
Sure, definitely. So as I mentioned, we've known for a while bone marrow transplant can be curative. I want to say one word though about, there is a question now, hey, what does curative mean? Let me go back to during the bone marrow transplant, because we do use the term curative with bone marrow transplant, but there's still questions of, say I wasn't, and usually you don't qualify for some of these, or it's not recommended that you do some of these therapies unless you have, or until you have certain complications. So, I remember with hydroxyurea, well, they wouldn't just start everybody on hydroxyurea. When I first started, you had to have, at least 3 hospitalizations within a year, or 1 event, like I had acute chest syndrome, or some other precipitating, some other event that happened that would make you a candidate for it. So, hey, you could have an individual with sickle cell, they're doing fine, and then they don't become a candidate because their sickle cell is not considered severe enough. So individuals that were qualifying for, say, let's bone marrow transplant was first started, they had to have some event that made it significant or severe on them. And so then when you use the term curative, well, hey, I've already had a stroke from sickle cell disease. Now you give me the bone marrow transplant. Sure, I don't have sickle cell disease anymore in the traditional sense, in that I'm making red blood cells that are defective, but I've already had a complication from sickle cell disease that's really significant. So can I call myself cured? I just wanted to say that because there's a lot of discussions going on right now about what does it mean to be cured from sickle cell disease. And even individuals that have had bone marrow transplants that have lived a lifetime with sickle cell disease, they may consider themselves, hey, I'm still part of the sickle cell community, even though I've been, quote, cured. And we have to figure out, hey, we have to accept those individuals as, hey, you still have that sickle cell lived experience. Now, to get back to the point you were making, yes, in 2020, I think it was at the end of 2023.
Oh, 2020, yeah.
Yeah, two new therapies for treating sickle cell disease were approved by the FDA. Both of them are what we call gene therapy in the sense that they're modifying the DNA of the implant, and you get it from someone that's not yourself. That's called allogeneic bone marrow transplant. When you get it from yourself, that's autologous bone marrow transplant. So with the new therapies that came out, both of those are autologous, meaning we're using your bone marrow to do the transplant. And what they do is they can harvest bone marrow from your tissue. Now, I'm not an expert, so definitely, I'm going to give you a broad overview, but it's going to be kind of broad, not too specific. But my understanding is that they take your bone marrow, they go in and they make changes or cuts in your DNA that what they actually do is turn on that fetal hemoglobin so that you start making more fetal hemoglobin. So it's not where they're actually correcting the mistake that was in the adult hemoglobin. What they're doing instead is just turning on your fetal hemoglobin so that you make more fetal hemoglobin. So the two companies that have this therapy are Bluebird Bio. They have one strategy for doing this. And then you have CRISPR, Vertex Therapeutics. And both of them, they will take your DNA, harvest the DNA from you, the bone marrow tissue from you. They will make changes to your bone marrow tissue by, as I said, turning on that fetal hemoglobin and then giving it back to you, where now you continuously make fetal hemoglobin at high enough levels, if the therapy works the way we intend it to, so that you don't have the problems related to sickle cell disease.
Thank you for that. And I would say that I am constantly learning about gene therapy as well. And it's so scientific and it's just so transformative. It's hard to wrap your head around it to understand, like on such a molecular level, what they're able to do with someone's DNA in the cells of their body. But I also want to say that the cost for gene therapy can be between $2 million and $3 million as an estimate. And although CMS, which is the Center for Medicaid and Medicare Services, has a cell and gene therapy access model where they're going to be partnering with state Medicaid programs to put together outcome-based contract agreements, the process and the cost of care to an individual, it still has to be negotiated. It takes about a year from time that you're included into these new protocols to the time you're cured. And one of the questions I have is, in these contracts, the state Medicaid programs do not have to work with community-based organizations. It's an option. Can you talk about that?
Yes, and there is a lot there. So I'm gonna ask you to come back to some of the questions and try to answer them as you presented them, and then go. So you're definitely right. The cost to these new gene therapies for treating sickle cell disease can be very expensive. And as I mentioned earlier, we've been having bone marrow transplant done for since the 1980s, as I mentioned earlier. If you were to talk to your hematologist, and of course, that's the first step, is to really go and talk to your doctor. If your doctor is not a hematologist, then asking your doctor to refer you to a hematologist. And then that hematologist may actually refer you even further to a transplant specialist that really focuses on sickle cell disease transplant. Because what you want to do first is figure out, hey, am I a good candidate for these new therapies? Now, the first thing that might happen is that they say, well, let's look at first, would you benefit from the bone marrow transplant that was done with a matching sibling donor? Because that's something we have a lot more experience in. We've been doing that a lot more often. And so that would probably be your first route to say, hey, do I just have a matching sibling donor that I can do a bone marrow transplant with them? And then next, they might also look for, hey, what about unrelated matched donor? That might be your second tier option. But if they can't find those, and there are complications with those, the biggest complication with your matching sibling donor or your unmatched donor is what's called graft versus host disease. That's something that can occur with the bone marrow transplant when it's done with a person that's not you. But you would still probably want to look at that route first. That does have some cost as well, but it's not as expensive as the new therapies that exist. If you're not able to find a matched sibling donor or an unrelated matched donor, then you would probably fall into that path of, well, we can do these gene therapies, this gene editing. And in that case, it is very expensive. And as you mentioned, what we look at for paying for that are insurance strategies that would help us to do that. About 55 to 70% of sickle cell patients are on Medicaid. So we would need to look for partnering or working with Medicaids. And Medicaid is like state specific. Every state has their own Medicaid program. But working with that Medicaid program to give access to those individuals with sickle cell disease. Now, fortunately, as you mentioned, CMS, the Center for Medicare and Medicaid Services, is looking at a payment model that could help with the cost of doing these bone marrow, these gene editing for sickle cell disease. Now, they are currently working with the pharmaceutical companies, the two that have this, Bluebird Bio and Vertex CRISPR, to look at developing that payment model. And the reason that CMS is a good candidate for looking at that is because then they have the whole nation that they can look at. So it's estimated to be 100,000 individuals with sickle cell disease. One state could go and negotiate with the pharmaceutical company on their own, but you have more power. There's power in numbers. And so if CMS would theoretically have more power to negotiate with these pharmaceutical companies, because they can say, hey, we have access to all of the sickle cell patients, whereas the state may only have access to a few sickle cell patients. So CMS is going to lay out these payment models for states to consider in January. So right now they're working on it, or it's actually going to come like towards the end of the year. They're going to present to the states, this is what we have. It will then be up to the state Medicaid programs to sign on to say, yes, we want to participate in the CMS based payment model initiative. Now, I will say, though, that there have been some states that have already started negotiating with the pharma companies. My understanding, and I'm pretty certain about this, is that Michigan, for example, has already negotiated with some of the pharmaceutical companies about doing it in Michigan. And, the question is, with CMS, as I've mentioned, they have the full numbers. There might be states that can negotiate good rates, but I would imagine that as we move forward, CMS will be able to come, because they have that bargaining power of the all of the sickle cell patients in the U.S., they can probably negotiate lower rates, but that remains to be seen. And of course, we would encourage all state Medicaids to move forward with negotiate, either through the CMS model or through their own model like Michigan did. But to look at models that help individuals with sickle cell disease get access to this. Now, I know the cost is great, but is the cost of doing nothing even more? I've been fortunate that I have benefited from hydroxyurea. And because of hydroxyurea, now, as I mentioned, I was in college. I had a really significant episode of acute chest syndrome. And then that kind of led to me being put on hydroxyurea. But before starting hydroxyurea, I would have like 3 or 4 crises per year that would require hospitalizations. And these hospitalizations would usually last 2 to 3 weeks. So, yeah, and very severe. Now, after hydroxyurea, I went to having 3 or 4 crises that would require hospitalizations. That's not counting the number of crises I had that I dealt with at home. And so it doesn't count the lost days of school or work that I'm dealing with at home. It's just counting the lost days of school and work that I'm in the hospital and the burden, the cost of that on the system. But with hydroxyurea, I was able to not only complete my undergraduate education, but also become a doctor. And I became a contributing member of society. I pay taxes at the higher tax bracket.
We appreciate you.
Yes, exactly. But when we look at the cost, of an individual with sickle cell disease, and you look at, the $3 million, yes, but if we're able to treat and cure this individual or prevent, at any rate, a stroke from happening, acute chest syndrome from happening, other significant conditions that would prevent that individual from becoming a working, thriving member of society, what's the cost of that, right? And so we have to look at, weighing that as a society. Sure, there's a large upfront cost, but there could be a huge benefit that comes from helping this individual to be relieved of some of the complications of sickle cell disease.
Yeah,
now,
and
to deal with your last question, I always would love to see community-based organizations, including use of community health workers, involved in improving the healthcare system. I can't speak towards one Medicaid. As I said, there's 50 different Medicaid programs. But I think by working with community-based organizations, you really give the patient and the patient community a voice in that decision-making process. As we move forward, and one of the reasons, you mentioned earlier that I went into public health is that while I was doing my residency in pediatrics, what I observed is that a lot of sickle cell patients were not taking hydroxyurea when I was in my residency. And the reason for that could be related to misinformation that the patients were receiving, misinformation that the doctors are receiving. The healthcare system isn't really set up to help patients really get on therapies that exist or that are there for us. So we have to figure out not only how do we find a cure for sickle cell disease or how do we find better methods of treating sickle cell disease, but how do we improve patient awareness about it? How do we improve patient access to it? How do we improve provider knowledge of these treatments so that we can more effectively utilize these treatments to treat sickle cell patients effectively? We could have the best cure in the world that's created, but if sickle cell patients don't access that, then, really, what is it worth? We have to figure out how to provide that education to sickle cell patients. We have to figure out how to make them more knowledgeable about that disease so that then they can become a partner in treating their sickle cell disease. It's very important that the sickle cell patients themselves play a very active role in treating their sickle cell disease. Now, historically, our medical system has been what we would call paternalistic, right? Oh, well, hey, there's the doctor and I'm the patient, and I'll just listen to what the doctor says without the doctor really taking into account my personal preferences, my personal situation, my social determinants of health. We need to look at a system that allows the patient voice to emerge, and using community-based organizations allows that to happen more effectively. So yes, there may be some states that would say, hey, because of cost or for other reasons, they're not going to engage the CBOs. I see that as a lost opportunity because I feel that community-based organizations, they have their ears to the ground. In many cases, they know what their patients are going through, both in the healthcare system as well as away from it. What are some of those social determinants of health factors that are playing a role in? And unless you have very, very sick patients that engage with the healthcare system often, most sickle cell patients have most of their life spent outside of the
Well,
healthcare.
99% of their
Yes,
life is spent outside of the healthcare
outside of it.
system.
So we need community-based organizations that's able to tie in that, hey, yes, we have the sickle cell disease that we have to treat, but we also have to look at the holistic person and how do we help that person live in society, continue to engage employment or school and do those other things that are needed to help them a whole person, make them a whole person.
Thank you so much for that. And I also want to say too, just a segue, is that if and I'm sure they have health economists looking at this, but I'm sure long term that the cost of curing a patient with gene therapy or bone marrow transplant probably is going to save the state money over time because you have a patient that's healthier, more productive in society, and less of a burden on the healthcare system. But before we end, I know that you were played a key role at HRSA in the US and decided to move to Canada. And was just like, wow, that was a change. But I just wanted you to talk about, in the United States, we have about 100,000 people that live with sickle cell. But what is the landscape like in Canada for accessing specialty care for sickle cell?
Yes. So I do live in an area that's right outside of Toronto. And I would say that Toronto has excellent hematologists that are available to treat sickle cell disease. My current doctor, Dr. Kevin, he's very effective, very knowledgeable about sickle cell disease. I don't know as much, but I do know a little bit about the Canadian system. And I know one of your questions is probably, well, how many individuals with sickle cell disease in Canada? I don't have an answer for that. I believe they just started doing newborn screening relatively recently. When I say relatively recently, it could have been the early 2000s, but unfortunately, I don't know the numbers. Now, I think though, when you look at sickle cell disease care and how effective it is, to a large extent, it's going to also include, do those individuals with sickle cell disease have effective access to those providers that have knowledge about sickle cell disease? You mentioned earlier that I worked at HRSA, the Health Resources and Services Administration, and prior to that, I worked at NHLBI on the guidelines. But at HRSA, one of the things that we wanted to do is figure out how do we take the knowledge that hematologists treating sickle cell disease have and spread it out to as many providers as possible so that they have some knowledge about treating sickle cell disease. One of the motivations for doing that is that, as you had mentioned earlier with hydroxyurea, so I had been taking hydroxyurea by the time I got to my residency for about 5, 6, 8 years. I was doing really well on it. But during my residency, what I noticed is that a lot of sickle cell patients didn't take hydroxyurea for a number of reasons. And in 2008, NHLBI did a study and they found that of the individuals that could benefit from hydroxyurea, only about 10% of those sickle cell patients were taking. That meant 90% of patients that could benefit from hydroxyurea were not taking it. Now, if we look at the reasons for that, well, one of the biggest reasons is lack of access to knowledgeable providers. Hematologists, to a large extent, are located at these large university medical centers. So there's going to be one at, like, let's say Duke and UNC and Wake Forest, and I'm using North Carolina as an example. But what happens to that sickle cell patient that lives, 2 hours from the closest hematologist that can prescribe hydroxyurea? What does their situation look like? And what we know is that, when I started taking hydroxyurea, well, okay, you start the hydroxyurea, you got to get blood tests every month, and the blood tests, to make sure that the levels aren't too high and are in that therapeutic zone, that they're treating the disease. So you had to get, you start hydroxyurea, you had a pharmacy that prescribed it, and then you had to have blood tests done every month, and you had to do all these things. And these can act as burdens to individuals that don't have access to that hematologist. So we have to figure out strategies that improve access by using networks of doctors that allow the individuals to get there. Now, I'm bringing it back
What about to Canada?
Yeah. So my observation so far has been that the sickle cell care in Canada is very good. I have talked to Dr. Coe, Kevin Coe, who's my doctor, and he said his average life expectancy for his patients is well into the 50s and 60s, which is wonderful, right? I mean, he's doing a great job. But like I live, like I guess in a suburb of Toronto. Toronto would be about a 45-minute drive to me. I do have a hospital that's close to me, but in order to get my care, and I do have access to the resources, I just go in to Toronto to Dr. Kevin Coe. You know, one of the biggest hallmarks of sickle cell disease is pain. I've been fortunate that on hydroxyurea, I don't get as many pain crises. But I haven't had too many sickle cell events. I've had other reasons I've had to go to the emergency room. And I will say that the wait in the emergency room in Canada, it feels longer. It's longer. It's a longer wait in the emergency room in Canada. But I would have to say that the care, though, that I received from Dr. Kevin Coe and from the hematologist is superb.
Well, thank you. I want to say thank you for that, and just say that perhaps there could be some type of alliance between the US and Canada when you were talking about how we can forge relationships, networks, and partners across country lines is what we need, and to have that conversation. I would love to meet Dr. Woe as well, and all of the great work he's doing. And it seems like in the more bigger metropolitan areas, the care for sickle cell is probably just as excellent, but still have the same struggles. If you live, I don't know, up in the northernmost areas, you probably won't be able to access Dr. Well. So just I want to thank you so much for talking today about transformative sickle cell care, and sharing with the community all of your expertise and knowledge about sickle cell and your work all over the country and advocating for our community. I want to say thank you. Before we end out, I just want to just put up a slide just to share about TOVA Talk series, and make sure that everyone knows that we will be linking it to our website on TOVA Health TV and on our YouTube channel, TOVA Tuesday. And if you'd like to learn more about TOVA Community Health, please visit our website at www.tovacommunityhealth.org and our TOVA Health TV channel at YouTube. If you would like to donate to this episode, we would appreciate it. Our Cash App is $TOVA Health, or our PayPal link is contact@tovacommunityhealth.org. Dr. Ivy, thank you so much for a very empowering talk today. And I'm very inspired by your work and have the energy to go out to do more for our community. Do you have any last minute comments or anything you want to share before we close out?
I just want to say one thing, and I didn't, we didn't go into the fact that there are other therapies. We talked about hydroxyurea. Of course, Pfizer came out with voxelotor, which is another therapy for treating sickle cell disease. So definitely, I encourage our audience to learn more about Oxbryta, voxelotor, as a possible treatment that's from Pfizer. Adakveo is another treatment that's used for the treatment of chronic pain. And then there are other therapies in the pipeline right now. So the last message I would just want to say is that we're in a great moment of hope for sickle cell disease. You had asked earlier about my childhood with sickle cell disease, and for the longest time, there wasn't any therapies for sickle cell disease. And then hydroxyurea came along, and then for the longest time, hydroxyurea was the only major therapy. I mean, you did have the bone marrow transplant, but that was very limited in who could benefit from that. But now we have so many more therapies out there to treat sickle cell disease. We have to figure out how to get this information to patients. And so thank you, Dr. Anderson, for doing this TOVA Talks, which helps us get that information to patients. It's been an honor. Thank you so much for inviting me to talk today. And I just want to leave with, there's a lot of hope right now. There's a lot of optimism. We can't sit back on our laurels though and wait for things. We got to continue to work and to continue to try to make the system better. But I do think we're at a wonderful time for sickle cell disease in terms of, you know, what's available now and what's in the pipeline. And so thank you so much.
And thank you, Dr. Ivy, for joining TOVA Talk series in honor of World Sickle Cell Day. Sorry. I'm inspired and empowered to continue serving the community and healing others with compassion. Thank you so much, and we'll see you soon.
Thank you. You have a nice day.